TopMedTalk.
Well, hello and good morning. It's TopMedTalk live here at Anesthesiology 2024. It's the annual meeting of the American Society of Anesthesiologists. Now, I'm your host, Desiree Chappell, and I'm joined by my co-host, Professor Mike Grocott. Hello, Mike. How are you?
Good morning, Desiree.
It's been a wonderful couple days so far.
It's been great. Another packed schedule of interviews today.
I think this is the most excited I've been about an interview in a very long time. No offense to all of our other guests, but just saying. We are so lucky to be able to catch up and sit down with Professor Henrik Kehlet. Henrik, thank you so much for sitting down with us on TopMedTalk.
Thank you for inviting me again. I'm fine.
Yes.
It's a pleasure.
We were talking about the last time we sat down was January, right before COVID
Yes,
really hit and took off everywhere. So it's been a while. How have you been?
I'm doing fine. I have a special job. I can do what I want, but I want to do research, and no, it's excellent.
Yeah.
Yep.
So, Henrik, for those who may not know who you are, can you just tell us a little bit about where you're located and where you are?
I'm a gastrointestinal surgeon by profession.
Oh, you're at an anesthesia meeting too, yeah?
Yeah, because anesthesia is a small part of recovery, so I have to go here. But then I stopped operating about 14 years ago, and now full-time research paid by the Copenhagen University. So that's great.
Yeah.
There's still so many challenges in enhanced recovery.
Yeah.
A lot.
So, Henrik, you really came into the world of anesthesia back, was it in the late 90s, early 2000s when you started talking about enhanced recovery after surgery? Back then, it was a lot of people knew it as fast track surgery, yeah?
Yeah, I think I came into anesthesia much before because I was interested in pain,
Right.
because that's a prerequisite for enhanced recovery. So we had to solve that problem more or less
Yeah.
before jumping into all the other factors of enhanced recovery. And therefore, I came to many anesthesia meetings and became friends with especially the gurus in regional anesthesia. Yeah. That was fun as a young surgeon to become good friends with all these famous people.
So you were coming to the anesthesia meetings, you were talking to us about pain management, and then realized, I think the famous question that you ask is, why are the patients still in the hospital?
There are two questions.
Okay.
One is, why in hospital?
Yeah.
The second thing is, enhanced recovery is recovery. And recovery is not hospital stay alone. It is also what happens when they go home. So there are two questions. The second one has unfortunately been more or less forgotten because it has been concentrated on hospital stay because of the economical benefits of that.
Mm-hmm. Which is unfortunate because there's been so much of a trend to send people home so much earlier,
Yeah.
even separate from enhanced recovery protocols and pathways.
Yeah.
We are just tending to try and get people out of the hospital, especially during COVID. I think accelerated that quite a bit.
Now, but you have to remember, enhanced recovery did not change discharge criteria. They were the same as before.
Right.
Yeah.
Right. So I want to kind of take a step back very quickly when we've talked about some different elements. But to you, and when you really started this journey, what does enhanced recovery actually mean? And how, and is it just getting them out? Is it, discharging the same way, or is it hoping to improve where they started from?
It started by analyzing why are you in hospital and why are you not recovering? And suddenly you have a list of 20 factors. And that was the initial stimulus to say, well, you can never solve that problem just by fluid management or by pain management or minimally invasive surgery. It has to be a package.
Package deal.
Yeah.
And then all the things that we're doing work synergistically.
Synergistic, yeah.
So core elements to you, every enhanced recovery program needs. What are the main ones?
Pain management, nursing care, surgical technique.
Mm-hmm. Avoid fluid overload.
Yeah, but you said the main ones. I mean, I think we solved the fluid problem, didn't we?
I'm not sure solved is the right answer, but we're on a journey.
It became better.
It became better.
I think there's more awareness about it. This is something I'm very passionate about. I think when enhanced recovery protocol said avoid fluid overload, that was misinterpreted as fluid restrict.
Exactly. And that was, unfortunately, again, we lost many years of
Mhm.
research because of that.
Yeah.
Yeah.
And so
It was not me who
No.
said fluid.
No accusation, don't worry. But it's an interesting phenomenon. I think it changed behaviour in a way that probably on occasions caused harm.
Yeah.
When we certainly, I mean, we've talked about this before, but in Southampton, we saw for the first time patients having hip and knee replacements turning up needing renal replacement. Not frequently, but occasionally. And I think that nuance of language is really important.
Yeah. And I was telling you that with Northstar Anesthesia, where I'm vice president of clinical quality, at all of our sites, I've looked at our protocols, so many that were developed even before we were there or during the last 10 years. And many of them, instead of having a goal directed fluid therapy approach or hemodynamic approach, or even saying avoid fluid overload, they just say fluid restrict.
Yeah.
And that's it. And still to this day. So we're kind of fighting an uphill battle a little bit.
Yeah. The other key problem is to realize it has to be procedure dependent. In perioperative medicine, we have too many guidelines for everything in one page, which is crazy because procedures have special problems and patients.
Yeah.
We are now realizing that. In fact, we have a symposium tomorrow about protocolization versus personalization. But you cannot talk about personalization before you have protocolized it.
So let's talk about this a little bit more because I get this question so much because the pushback of any kind of protocol that we would put out, regardless of whether it's enhanced recovery or GDT protocol or pain management or SSI prevention, whatever it is, a lot of people push back to say that's cookbook and I don't want someone telling me how to do anesthesia.
Yeah. That's a problem in medicine because if you introduce personalization, then you introduce total anarchy.
It doesn't have to be, but it often is. And
It often is before we are able to really characterize persons.
Yes.
And there are some fascinating data out from Stanford about the individual variability for the same surgery in their inflammatory and immunological responses, which correlates to recovery. And then we are down to personalization. I mean, physiologically, not psychologically. But too many people jump into the psychological aspects. I'm not saying they're not important, but I think we have to solve all these somatic problems before we go too much into psychology. Because you cannot solve the risk of having an operation by psychological interventions. I don't think so.
Yeah.
No.
So it seems like and what I hear you saying is that we still have to have a protocol or standard approach that give us guardrails.
Yeah.
And then we take that to be able to individualize and personalize the care using these sets of kind of not rules, but guidance.
Yeah, and there are several ways to do it. I mean, we know that we have pain catastrophizers, and they can be identified easily.
Yeah.
But then we have these hyper-inflammatory patients, and they cannot be identified easily.
yet.
Yes.
I mean, hopefully that's what's coming with the individual.
Oh, it will.
Yeah.
Definitely will.
So, well, let's double click on that because that is something that I know. The last time we talked to you, this was the space that you were really getting into and diving into. So, tell us a little bit more what's come out in the last several years about this.
I'm personally biased here, but I think all the studies to modify inflammation by steroids that we have learned a lot also about protocolization and personalizing, because in minor surgery, you don't need to give so much modifying things. But in major surgery, and that's one of my favorite research topics now, because we have all this trial debate in perioperative medicine and pragmatic trials and whatever they call it. And they all forget about the physiology. I don't know if you have seen, no, we can take an example. The regain trial outcome, walking ability 2 months after a hip fracture operation. Can you tell me why a spinal should modify that outcome when a spinal has no important effect on all these inflammatory responses or any long-term effects on recovery?
Well, unless it goes horribly wrong. But that's a separate question.
Well, actually, yeah.
No, but it continues. I mean, other trials, big cluster RCTs investigating a single shot of spinal morphine on recovery for 60 days after a wibble. What is the physiological explanation behind that? We have to go back. We lost 20 years of research on preemptive anesthesia because Patrick Wall, with his cigarette and his rats, were looking at pinching and showed that hyperalgesia could be prevented by a preemptive block, but there was no injury. There was just a mechanical pinching. So we have to think about an operation is tissue injury. And if you have an intervention that has a certain duration, usually short term, but the responses continue, I think that's the biggest challenge in perioperative medicine, to understand that so that we can have interventions with a duration that correlates with the injury responses.
Yeah.
In order to enhance recovery, really.
Or at least has got a plausible biological mechanism to alter the trajectory of those responses. Because you could argue that a steroid dose is it can be a single shot, but you can change the dynamic of that inflammatory response.
You can modify it, but the problem with steroids is that you cannot repeat it too many times.
The last time we talked, we were talking about steroid dosing before surgery.
Yeah.
And have we seen that it has made a major impact on inflammatory response?
Yes.
Yeah.
Yep.
Oh, look who's joined us.
Oh.
My goodness.
Hello.
Everyone.
Familiar face?
Someone that is only second to Henrik.
It's the other silver fox.
Oh, Monty Mythen. Thanks for joining us.
I couldn't resist. Professor Henrik Kehlet, how are you?
I am fine.
Great.
Great company here, so
Well,
now even better.
Oh, thank you. Very kind. Very kind.
we're doing a bit of a deep dive into enhanced recovery because you knew I couldn't not ask about that. Let's pull it back up since Monty's here because I would love his opinion. He's been making some rounds in facilities across the U.S. So, Henrik, I feel like there's a major renaissance for enhanced recovery here, at least within the U.S. I don't have a pulse on the rest of the world, but what do you think about that?
The concept of enhanced recovery is difficult because we have all these guidelines with 30 factors and people cannot accept so many changes. So it takes time to implement it, but it has taken too long.
Long time.
Too long.
25 years we're looking at some places.
Yeah. But even if you do what we think is the right thing now, patients still have problems.
Yes.
It's still dangerous to have an operation.
Yes.
So there are several phases. One thing is to do what you should do. The next thing is, how can we be better?
So I'm going to ask quite a specific question because, Monty, you've been an advocate of the dream notion. So that using early drinking, eating and mobilizing after surgery is both a target and a measure of success. How does that sit with you, Henrik, as a way of helping people on the journey to enhance recovery?
English is not my native language, but dream, the criteria were already included in enhanced recovery.
Yeah.
Of course.
Simple and understandable. Yeah.
If I can come in, Desiree, for a second, I think coming late to the game compared to you, Henrik, if I may, the simplicity of focusing on the drink, eat, mobilize bit is you can then tell people not to worry so much about the 30 factors they've got obsessed with.
Yeah.
The 4 pillars you originally presented are the key components. And if you achieve the drink, eat, Mobilize, you've probably done the bits before it okay.
Yes. But we all know that they do not all achieve it.
No.
So the question is, why not?
So that brings us back to the pathophysiology, which we're not investing enough in understanding.
No.
And surgery has changed. So a robotic cystectomy, for example, has pathophysiological perturbations that we do not fully understand that limits people drinking, eating, and moving.
No.
And we should go back to understanding what's going on.
Exactly. That you bring it up because I was listening to a symposium yesterday about preoperative risk assessment. Very complicated, and they all forget about the data that they are concluding from are based on procedures without enhanced recovery, which by itself reduces medical complications if it is done right by at least 50%. And they don't include what you were just touching upon, the introduction of smaller stressful surgery by minimally invasive surgery. So all this risk assessment, that's another topic where we have challenges because it's based on old data with higher risk for surgery.
And on that journey, is a laparoscopic right hemicolectomy less stressful than a robotic hemicolectomy?
I don't think so.
Exactly. So I think,
They are one of my favorite topics. Minimally invasive surgery, how should we assess it? Because the surgeons are so biased.
Yes.
Yeah.
So as I will talk about on Tuesday again and again and again, you have to do these studies double-blind with a dressing over the abdomen. The surgeon is not allowed to go rounds to introduce bias on recovery. There are 2 studies with fully implemented enhanced recovery. One is robotic cystectomy we published half a year ago. Length of stay was 4 or 5 days. No difference. Open versus robotic. No difference.
And I'm sure you touched on it earlier on as one of the world's most famous anesthesiologists. You're actually a surgeon. Yes.
We established that one early on.
No, but it's interesting. But minimal invasive surgery has the other benefits that the early recovery. It has to be integrated to get the full benefits of enhanced recovery and minimally invasive surgery.
And do you think we should reasonably believe that robotic surgery will give us an incremental benefit above laparoscopic surgery, which clearly was a difference? I mean, you can see that in the inflammatory profiles, etc. But will robotic be another step forward?
I think it's a step back for some of the influence.
I say one thing that the robots can do better than anything else is go to get access to some difficult areas in the body, in the
pelvis.
Deep pelvis, throat cancer, for instance. There are special circumstances, but to do a robotic inguinal hernia operation, that's one of the biggest overkill in surgery.
We're seeing that quite a bit.
Yeah.
All right. Well, if someone is just now starting an enhanced recovery program, what would you say to keep it simple? Like, what are the things we need to focus on? Because I think we're starting to get really wrapped up into these 30 things and we have a lot of false starts and can't get it done.
But I agree with Monty. Use the dreaming stuff. And then if they cannot do it, you ask, why not? Was it because they vomited all the time, or they couldn't walk because of pain, or what was it? But those criteria are so simple that almost everybody in the hospital should be able to understand.
Patient does understand it.
Yeah.
You give them the chance. They say, no, I've got to get up.
Yeah.
I'm ready to go.
And we have posters around our hospital now about that, not just relating to surgery, I mean, relating to our medical patients as well.
Yeah. All right. So you're giving a lecture, an Eponymous lecture on Tuesday. Tell us a little bit about the Severing House lecture that you're going to be giving. What are some highlights from that?
Yeah, it's a little about the history of surgical pathophysiology with Francis Moore, who believed that God designed the responses and we should never interfere. That was interesting.
Wow.
We had severe discussions. But I will just update not the results of enhanced recovery, because this is well known, but the challenges to move forward, the challenges to design studies like the Prato meeting,
Yes.
where we have a huge diversity between some people who want to be big studies, mixing everything together, versus other people who are focused, procedure, patient-specific. I'll talk about that. I will also touch about some other challenges we have in perioperative medicine. We don't talk too much about it. But if you're interested in, which I'm not, in systematic reviews, too much of guidelines, fake medicine.
Oh.
I mean, even in Nature and economic journals, they publish repeatedly about fake medicine. And that's a huge problem because, and I have experienced it personally because of some Chinese colleagues, because there's this diversity between countries. Some countries,
I mean,
and with the AI, who cannot differentiate what is fake and what is real, and they put it all in the computer, and you get the end result saying we have 8.5 RCTs showing on average this result that goes into the guideline. That's a challenge. Also in enhanced recovery.
Mm-hmm.
Yeah.
so as a journal editor, I struggle to understand, except for the most well-resourced largest journals where they can get their hands on source data and have verification from department heads, that kind of thing. I struggle to understand how the journals can begin to deal with this.
It's difficult.
Yeah, the peer review process is... Peer reviewers are not going to detect this in most cases.
Nope.
And they get it wrong. It's really difficult.
But this is important also, especially in perioperative medicine, but also in enhanced recovery, to dissect the literature. What is really an advantage and what is pure nonsense?
But if you do the in-house voyage of discovery, like Desiree leads a group that does that, and you keep it simple, you haven't sat out of bed, you haven't had breakfast, you haven't been for a walk, why? And then let's look upstream. We can create our own evidence, can't we? We might get guidance from some of the fake and some of the real, but we can do our own voyage of discovery.
Two things. One thing is I'm a little bit worried because we do continue to look for the magic bullet of the one thing that makes the biggest difference in enhanced recovery instead of still continue to look at it from a holistic approach. So that's tough. Two, I still feel like there is a major pushback for some of these things. For instance, for dreaming, we are now doing so many outpatient procedures that we never would have done, or they're just staying there for 24 hours. So the concept is a little bit difficult if you're doing outpatient procedures because they go home and you never know how they do unless they come back. And so to me, I'd say this is what we need to be doing and looking at drinking, eating, and moving after surgery. But I get a little bit of pushback on that now because everybody goes home. So it's tough. I mean, it's just a tough one. I mean, presumably if they're going home, they're drinking, eating, and moving.
Maybe.
But we don't do follow-up with them to know if anybody's actually feeding them, giving them.
Some systems do, and some systems do it very effectively with a text or a phone call.
Yeah.
Are you okay? Y/N.
Yeah.
Why?
Yeah. Which is what we need to be doing. We're making a case for that for sure.
Yeah. But we touched upon that from the beginning before you came, that enhanced recovery is divided into two phases, in hospital and after. And we have too little research in after discharge. I'll give you an example. I will present it on Tuesday to fast-track lung cancer surgery, median stay 2 days. 2 days. But that was not the purpose. The purpose was to analyze those patients who stayed more than 48 hours. And it turned out that it was pain and pulmonary issues and air leak. But then after discharge, we had monitors on them. And we had monitors on them 4 days before surgery. And then their activity after going home 2 days post-op was reduced by 40%. Right? most people would say, okay, you had a lung cancer operation. Of course you are not out, because that was the purpose of the study, to analyze why. And it was fatigue and pain.
Mhm.
And then several smaller things. But fatigue and pain. And then we are back to the inflammatory response and how to modify. But this was minimal invasive surgery. So
Where's the pain? So it's a full circle of where you started all of your research and your work to pain management and inflammatory response.
Yeah.
Wow. Well, Henrik, it's always amazing to catch up
Yeah.
with you. Thank you so much for taking the time
Yep.
out. I know that
Thank
you're
you.
very, very busy. But we really appreciate you.
Yep.
Thank you.
Thank
I'm
you.
really looking forward to your lecture on Tuesday.
Yes,
Thank
absolutely.
you again.
All right. And thank you for listening to Top Med Talk. You know, you can find us on your favorite social media platform. If you find us on YouTube or Twitter or, X, LinkedIn, Facebook, please subscribe to our channel. Give us likes. Every little bit helps. Again, thank you to our sponsors and the American Society of Anesthesiologists for all the support to be here at Anesthesiology 2024. Cheers, everybody.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.